Let me just quickly welcome all our participants on the second day of the workshop on providing telemedicine for rural areas. Yesterday, we had a very long discussion on different challenges of telemedicine and also some of the cases from India. You learned about a few grassroots level initiatives and also some large initiatives like the doctor from the Apollo. Today, we will be talking about experience of telemedicine implementation in rural area, where Dr. Murthy Gokula has joined us from Toledo, Ohio, from the US. And he will be taking you through several things. He will be talking about some of his own work and the model that he has done in the US, and try to kind of will find out some of the learning points from here. After this session, this is the last technical session of the program. After this session, we will have a discussion with you, and where I hope to take your inputs and your insights on how to kind of take it forward and what next can be done. So I hope that all of you stay with us till the end of the program. And at the end of the program, also, again, today we will take your feedback. And before we start the session, I would also like to remind you that please do register yourself at the training management portal, because it's important for us. We need to take your attendance, we need to take your feedback. So please do that. With that, let me shortly introduce our speaker today. Dr. Murthy Gokula has earned his medical degree at Siddhartha Medical College in India. He completed his family medicine residency at Sparrow Hospital, Michigan State University in Lansing, Michigan. After the residency, he continued his training at the University of Michigan and completed a fellowship in geriatrics and became board certified in family medicine and geriatrics. He has been contributing to the clinical practice guidelines for American Medical Directors Association. He developed a stay home model for care for the elderly in nursing homes, assisted living, and independent living facilities. He is devoted to incorporating this model in post acute and home care together with the use of telemedicine and remote patient monitoring to properly improve function and quality of life. So Dr. Gokula's association with telemedicine is a little older than COVID. He has been working on it for quite a long time. And we are really excited to have him here today to kind of talk about his experience and talk about the initiatives that he's taking. Over to you, Dr. Gokula.
Thank you very much, Ruchira. But I have to tell you that today will be one of the most important days in my life because Dr. Satkival has invited me to speak here. And it is one of my dream as a child to kind of do two things. One is to understand the purpose of my life, and I got into spirituality and I'm into meditation. And the other one is to be a doctor to serve humanity. And when I went to Siddhartha Medical College in Vijayawada and I came back to Hyderabad, I left India in 95. During this time, when I was in med school, I adopted an orphanage for health. And when I was in Hyderabad, I still remember that there was no penicillin in the rural health center near Gandipet. And I gave amoxicillin to the person, and he literally threw that on my face and walked away. So the penicillin and amoxicillin, they do the same. So the level of health literacy, trying to help him understand, it really didn't work. So that kind of stayed with me to say, how do I help rural health? How do we bridge? I mean, it was just an hour drive from Hyderabad, but still there was huge amount of literacy issues. So my childhood dream was to disrupt primary care in rural area. So that's how I got into family medicine and geriatrics. And now I'm excited that I'm into lifestyle medicine. I got board certified, and I'm just now doing another fellowship called anti-aging. Now I know how to give wellness, how to give health care, not just sick care. So with that, I started my research in Foley catheters and created an indication sheet and did that. And somewhere in 2011, one of my friend got uh, a grant in University of Pittsburgh Medical Center, and that's how I got into telemedicine. But before that, I actually did something in Assam, so I'll walk through my journey. So I just wanted to say, what stay home model is: strategic team activities yielding high outcomes and minimizing expenditure. That's what the grant I wrote, but the university, they made a mistake and it didn't see light. So I said I left the university in 16. I was a professor all my life, and now I'm trying to do it by myself. And that's when in 2013 I started doing things in India, and I'll explain my journey. I don't need to kind of elaborate the problems, but this is what I found. Not enough people in rural area to be really trained physicians, specialist care. There's a lot of infrastructure gap and poor access, long and diagnostic capabilities are a problem, and documentation is a problem, and the delay in appropriate care.
So your
So,
slides are not changing. Are you using the slides? It's not changing here.
oh,
Yeah.
yeah, I'm changing the slides.
But it has not changed here. I think still the first slide is visible for us.
Oh, how about this?
No, sir, no movement at all.
Sir, actually, we are only seeing the file, the PPT file. We are not able to see the slideshow. So if you share
So, how
your
about
entire,
this?
Now
yes,
it's
now
okay.
we can see.
Now you're moved. Yeah.
Oh, so now I can't. Okay, I have to do the small screen. That's fine.
Yeah.
So, see, my this picture should speak thousand words. I'm sorry. Thanks for telling me, Dr. Satkwal. Um, so, I found that if I can create a healthcare worker from the rural area, somebody who is doing ordinary work, and teach them and help them understand, and I think that will change. I'm not saying that this is the lady who is supposed to do, but somebody who is from the area, and I tried several things, but they didn't really help. And right now, for the pilot, I'll talk to you what I'm planning to do, how to kind of bridge, use the telemedicine solutions that we have, trying to do the diagnostic capabilities and the travel time, access, screening programs, and the technology to be transparent. You all know that you can do acute visits, follow up, primary care, specialty, remote post hospitalization, chronic disease management, school based health support, assisted living, center support, employee health. All this can be done pretty well, and there is enough data. And I pulled up this document, Pan India Telemedicine Network. I'm sure you all have heard enough, but they also have some of the problem statements that talk about uh, excuse me, a lot of discrepancy between the uniformity. So there is a heterogeneity of how partnerships are formed and who owns it and what. And at the end, I'll talk about an Australian model, what actually helped them to succeed in rural telemedicine. So the government doctors don't have this skill, and the consultations are kind of by the private partners are done well with the center setup, but with the government, how much? I'm sure you all know the e-Sanjeevani and other networks that have been formed, and who actually owns this and how it's done. It's all varied, and this was the future expansion from that document that they wanted to use medical colleges and trying to kind of give them health and wellness centers, and with using state medical college, and now the government has tried to put some chronic disease centers and Ayush people, the Asha paramedics, aspirational districts, all these things. I actually did my project in Mahbub Nagar, which was a aspirational district. Um, and then the training modules, this all becomes very complex. And look at the network content generation platform, medex platform, digital medical library, and some online certificate courses and CMEs. uh, you can kind of keep on going how it's being planned in India. But I try to I'm a geriatric specialist, so I try to create simplicity from complexity to manage multimorbidity, which means when you're older adult 65 and above, you have multiple medical problems. So I try to look at all of these medical problems, and my outcomes are function, quality of life. Same way with this complex. I mean, what one thing I've noticed in India is everything's on paper perfect. They're very intelligent, they create all these documents and everything works, but when you actually go and see what's really working, I mean, kind of it's not uniform, to say it well. And you see the role of government, everybody is trying to do their own little thing, and but the point is, how do you create a sense of uniform model of experience? So my job is today to create, walk you through the journey. So in 2011 to 12, I had an opportunity to move back to India, and I went to meet my spiritual master, and I told him that, I want to do this rural health, and so he asked me to meet a doctor from Apollo in Chennai, and I kind of he was doing it privately, so I invested some money, and it was a desktop software doing geriatric consults in Assam, and I found out that basically that center was more or less a funneling platform to Apollo hospitals. So there was a so that kind of disheartened me, and I left that. And then I found Washington Post about Health Cubed, and I read through that. I talked to the Health Cube people, and which is I'll show you the device. It can do about 34 tests, point of care testing, and they had a digital platform. And I reached out to them, and I integrated Zoom, and I integrated a stethoscope, and then integrated an electronic medical record from US called the RelyMed, and we use that, but the uptake was not all that great. The connectivity problems were there, and educating the ASHA ANMs. I want to make it very clear here. I think anything we try to do with ASHA and ANMs as far as telemedicine, I think is doomed to fail. We tried several methods of trying to encourage coax, uh, including financial incentives. But telemedicine, at least this is all pre-COVID. I don't know what's happening after COVID, but this is, I'm talking about 2013. Despite everything there, they were burdened with so many programs that are shoved down to their throat. This program, that program, this program, district collector says something. So there's a lot of things that noise that comes across them, and this becomes of least important for them when it's primary care. So uh, we did that, and then I'll kind of talk about the student health platform and the my GTC platform that we did after all that. I'll walk you through the journey. So this is how an health cube looks like, and they have a nice ecosystem wherein the instrument there is an application, web services, and implementation. We do point of care testing, and I've took up this HIPAA compliant HL7 compliant solution called RelyMed. My friend's wife owns this, and they have everything: self schedule, send messages, treatment requests, like, and then everybody can view the chart notes, lab results, make payments. So we actually connected the rural center through the ANM, through the PHC, to the district, and we just did a pilot. And again, the lethargy of the administration, the lethargy of the interest. They all say it's all a great idea, it looks great, and it's there's a wow factor, but the limitations, uh, despite having everything, it had a practice management, revenue cycle, patient engagement, and it was certified very strong. And we focused on patient education, and but still it was complex for the ASHA worker to use, because this was not a cloud based platform. This was a Microsoft client server based platform. So we had to have a laptop. We give the laptop. Sometimes the limitations with them are to actually know how to even navigate through the laptop and manage that. I'm not so sure what, I'm sure things have changed now, but we had a lot of those issues, and we actually presented this as telemedicine, Telangana telemedicine program to Mahbubnagar through the aspirational district. Mr. Reddy was the MP over there, and we used the Health Cube, and we wanted to kind of see how we can integrate uh, a bidirectional flow of information and advice. And we put this in place. The collector approved, and we talked about what needs to be done. We told them we have the technology, we have the web portal, we have the lab facilities, the electronic medical record, and we went through it to training, and everything was working perfectly. We created a very simple workflow. The ASHA registered patients and prints an ID card for each, because this was the health card for them, and they check the vitals, input the symptoms, and do labs based on that, and they do the visit with the doctor, dispense medications, and then, and we also talked about where they're satisfied with the patient, and we gave them, we trained the worker, and in places where we didn't have much of staff, we looked at an RMP doctor, and that also did not really work because they didn't have the incentive. They would make more money trying to funnel patients elsewhere, and we even tried the social entrepreneurship. So Dr. Satgwell, Dr. Ramesh, this is where I think we tried a lot with Health Cubed instrument to get loans through the
So,
district collector, and the it was cost prohibitive. It was like a lakh of rupees, and the basic. So it was very difficult to kind of get that entrepreneur model, even though it was backed by Health Cube.
okay.
So trying to give all these things, and uh, so the long term, I'm also giving the limitations, what we went through, and how I modified, and I didn't give up my vision to transform primary care in rural health, and uh, we tried with ASHA worker, the PHC staff, the RMP, social entrepreneur, and each time we had our own challenges. The challenges are sometimes related to bandwidth, which you all know, sometimes related with the person, sometimes related to the lack of interest to do this, uh, lack of any financial incentives aligned, lack of infrastructure for them, and sometimes the things were missing. And it's very expensive to replace all these things. Uh, so uh, when this we actually showed comparative costs too. Doctor interaction with telemedicine was only 100, regular was 200, and our labs costed only 130, and the last time 1 to 2 hours, and we had only 10 minutes, and it was at the doorstep. In terms of travel, they were traveling on average. So we were pretty good in places where it worked, and it really changed. It increased patient satisfaction, quality, and access to specialists, reduced cost travel, which you all know. And one thing is, uh, here I want to kind of see, Dr. Ramesh, did you hear about Project Echo, ECHO?
No, sir. No, no, no,
Okay.
no.
So I think that is something that, if you don't mind, I'll talk about it a little bit.
Okay,
It's called Extension of Community Healthcare Outcomes.
okay,
So this is a not-for-profit organization that is in the state of New Mexico. It is actually an Indian who invented this model called Echo. It's called Project Echo, and
okay,
uh, what the basis is that he really got grants and showed that using a simple Zoom platform and taking out all the hoopla, you make everybody in the ecosystem enablers of knowledge diffusion and transfer from rural to uh, the university setting. He didn't put anything much uh, complicated in between. It was just the video conferencing, but then it is a very very tight program, very well run, and the state government actually funds it along with the university. We call that state line item in the budget. So and then he started going around the world, and now we have Project Echo in India, and anybody can become a hub for Project Echo, and it's a not-for-profit, and it's done. So it all started in New Mexico because there was a lot of hepatitis cases, and for them to see a gastroenterologist, Dr. Sanjeev Arora is the gastroenterologist. It used to be like 3 months, and with now he actually does a clinic and trains the rural providers on what are the simple diagnostic tests that you should do. How do you manage based on the labs, what are the medications you should give. And and I have done those sessions, and it's amazing that we have what is called physician assistants and nurse practitioners here who are really so well ingrained with knowledge about hepatitis. They are better than an MD general medicine doctor in managing hepatitis. So, so that's how they do substance abuse. They do geriatrics. They do everything, and it's all research based, evidence based, very well run program. When I was a state president, I used Project Echo to disseminate best practices in, uh, we call them choosing wisely program, wherein we just pick 10 things, 10 unnecessary things to do for patients. uh, if I have to do something in rural India, based on my experience, avoid unnecessary antibiotics, pick up the common 10 conditions and educate the RMPs. I even tried that. I invited 300 RMPs in Nellore and wanted to educate them, give them a certificate course about the most common problems in the rural areas, and give them protocols. They were least interested in getting that education. I said, I'll give you a certificate from university here, but they had no incentive. But this is what Project Echo is. It's diffusion of knowledge, uh, and wherein using it simple and then changing clinical outcomes. So uh, we used the stethoscope and we were able to hear the heart sounds well, and Zoom, and we kind of pretty much did all this: blood pressure, pulse, temperature, pregnancy, hemoglobin, blood glucose, cholesterol. Again, cholesterol is very expensive, 200 rupees. Hepatitis, syphilis, malaria, we could check, and then we were able to intervene. It is not, you get only positive, negative, you don't get the numbers, but still that was good enough that we intervened, and we actually uh, documented, and we were able to kind of talk about their treatment history. It was documented. It didn't matter who came, the electronic medical record was there. And because it was an American system, there were drug interactions, and we kind of were able to do public health related analysis. Uh, but I found of all the technologies, Zoom was the lowest bandwidth that worked well. And this is the echo stethoscope that we used, that you can actually listen this heart sounds, and you can see the EKG, and it worked very well. And we integrated uh, through this web portal, and which people were able to self schedule whenever they wanted and send messages, and it worked nicely for us. But again, we did it in five districts, and uh, Anantapur, Nandurbar in Maharashtra, Jai Shankar, Mahbubnagar, Karimnagar, and uh, kind of we created a workflow. And the problem is the sustainability of this. As long as you have CSR funding, it will be helpful, but uh, recruitment of manpower was, and we actually created a model wherein one of the there is a book called Doctors, uh, uh, I'm blocking out the name, but Dr. Ramesh, we use that in Guatemala, and to train people. It's a very good book. It's even in Telugu and everywhere.
Where there
That
is no
book.
doctor, sir?
Where there is no doctors. So we kind of use that model, and to train people and the household about their common conditions. Because I didn't, I strongly believe you don't have to teach everybody the whole medicine. You find the common things that are causing problems, and then you just give three or four red flags. This is danger, you need to really get attention. But what happens in rural health is they wait, and they don't understand what's going on, and when it's serious, they end up in the hospitals and consume the healthcare system and their health too. So we kind of used all the four, as I said, based on the availability, and we conducted eye tests for these people, and we had the abnormal diagnostics. We created a health education, and we talked about non-clinical interventions for poor hygiene, and and we made list of clinical interventions that need to be done at the local level. And if there is an acute thing, they could make a appointment, and we actually made sure that we close each intervention. And so we had a project manager for the pilot, and we evaluated and monitored. So this was how we finally integrated telemedicine to the patient workflow. And we thought that somebody who's managing the technology should be well trained, and and they should feel that they own this. Without the ownership, it's not going to work in rural areas. And we simplified the process, and uh, we made sure that they were comfortable like a month or so till they are able to use the technology well. And then we identified a champion for telehealth within the local health center, and we integrated finally into the everyday care. And what we found is it requires building external relationship among providers, administrators, other clinical staff at the originating site. So, and then after this project, we screened with Health Cubed about 2.5 lakh people, Dr. Ramesh, in Telangana using CSR funds. But some of them were actual projects, but most of it was doing screening for anemia and all that. But there was not much. We just used Zoom and then help people. But after that, what I did is I actually moved on to do a school project with the state health. But they were expecting through a foundation that since I am coming from America, I'm supposed to give them Health Cubed free of cost. I tried to talk to Health Cube people, and they said no, we cannot do that. So that failed. I lost 10 lakhs trying to do that. But finally, then after that, I started a global teleclinics, uh, and I started creating uh, my own platform to do telemedicine. So I'll talk about this. Uh, So a student health program that really didn't pan out because of the cost prohibition again to give Health Cubed. So I created a platform simple, and I actually took care of COVID people, even though it's not, it's for a company we did 1,000 people, employees, and we actually, there were about 250 to 300 COVID positive patients, and our admission rate was 3%. So with the platform, I was able to manage, and there was an American organization called APTA. We formed collaboration with them with the platform I did. But one thing I realized very quickly is that to scale my platform, I needed a lot of money, which again is a problem. So again, my lessons learned is don't invent technology. There's a lot of people who have already done that, and I'll talk about that. And we, I was uh, I was looking at other platforms that came out after COVID, uh, and they each of them have their own benefits and problems. But there is an Adopt a Village project uh, in uh, in API, the American Association of Physicians of Indian origin, and they actually gave me an opportunity. And the president then, Anupama Gotimukala, had a vision to screen 75 villages, and for uh, for the 75th anniversary of India independence. So she knew that I did a lot of rural health work, and we both partnered. And Global Teleclinics was the implementation partner. And I tried to use the platform again. The scalability was a problem. So what we did was we our mission was to bring non-communicable diseases screening and prevention to rural people at their doorsteps of India. And why did I become passionate about non-communicable diseases? Because in primary care, this is what you see: blood pressure, cholesterol, diabetes, heart disease, stroke, and it is rising. And just to give you a statistics, every fifth diabetic on this earth is an Indian. So that I learned all that statistics when I recently did my lifestyle medicine uh, board exam. And I thought, rather than doing this rural, why don't I do this in the rural and create a staged approach? And we wanted to kind of do disease management and disease reversal, and see if we can improve health outcomes and connect rural India with medical providers and partners. So our goal was to screen 75 villages for hypertension, diabetes, anemia, chronic kidney disease, hyperlipidemia on the eve of 75 years of independence. So far, we have screened about 51 villages and screened more than 6,000 patients. So how does this work? So the way it works is, the one of the American doctor here who is an RP member will actually donate $2,500, $2,500, and I adopted one village which is my mother-in-law's and on her name, and we actually say this is the village we want to do it. And since I have connections in the village, we identify a champion. So we talk to the champion and we'll explain to them the program about screening the health condition, which is phase one. And global teleclinics, we work with them, and we used a nationally accredited uh, lab, which is called SRL Diagnostics. And we got labs because my thought process is let's pilot this in few people, get solid labs, and then do the intervention. And we analyze the data, and we actually call the patients and explain to them the test results, and we give them primary care support for all the positive patients. And this is the program that we started, and we wanted to kind of uh, screen and make sure that we do top five disease and top five preconditions, and then do lifestyle interventions. And we gave reports to the sponsor, and I can show you once I finish this uh, by going to the website. I can share that. You all can see it. The study the what we did statistical analysis, and then we actually wanted to do a private public model, and kind of bring in social entrepreneur service partners, and for adoption. So I've created like three phases, and I wanted this to be a sustainable project. And we did screen the phase one, and if you look at the cumulative results, like we chose only 4 states. These are people who are just coming off the streets. The way we do it is we tell in the village that we're going to do a screening program, and just random people show up, and look at the amount of disease burden they have. Abnormal BMI. Gujarat is the highest, 34, Telangana 24, Andhra Pradesh 22, Karnataka 22. I mean, this is scary for India if the rural people have abnormal BMI. And if you look at the chronic kidney disease, AP has like 36.28 for all the cumulative results for the 6,000. I mean, for the people we screened, about 15 villages. In Telangana, 20%. So these are like asymptomatic. They don't know that they are living with chronic kidney disease. And the criteria was creatinine of 1.3 and above. And BMI was 20, 24 is what we used. Uh, and then look at the amount of diabetes we have. Karnataka 34.6, Andhra Pradesh 27, Telangana 23, Gujarat 18. So the anemia, people focus Andhra and Telangana. These are real results, from an accredited lab, and it seems like Gujarat is scaling high, uh, and Karnataka. Uh, followed by Andhra and Telangana, and Karnataka is the least anemic of, because we chose these 4 because we going to do pilot, excuse me, in these 4 states. So because first thing is, if we identify the disease burden, then we can actually start intervention. So if you look at the abnormal BP, which Karnataka has almost 47, I mean, on the villages, 4 villages we screened, half of them had a elevated blood pressure. And just to kind of, when we took the history, the doctor, it's the salt intake that's directly correlates with the amount of blood pressure that you can see, and cholesterol also you can see. So if you see Karnataka is diabetic, high cholesterol Karnataka, so they might be eating very rich food, which we got that through the history. Because what happens is, after screening, about 10 days later we get the labs, we send all the hard copies to the village champion, and one of our doctors calls them or does a video visit and explains to them the results, and tells them to buy the medication if they need medication, or go help them go to the primary health center. And that's the closure for the first phase. And if you look at the cholesterol Andhra, and they, when they call the patient, they take a brief food history, nutrition history, and it's pretty bad how food habits have changed in rural India. And if you look at the HDL and LDL abnormalities also, so high, but HDL is the good cholesterol. So we, but still you can have the bad portion of the good cholesterol. So my gut feeling is, if you fractionate the HDL, you'll have the dense HDL, which you don't want it. Uh, so if you can see the amount of disease burden, it's pretty scary uh, at each of this cholesterol abnormalities in rural health. And triglycerides also, Karnataka has the highest. And metabolic syndrome, which is elevated cholesterol. So, so the point is, here is the, I can share this. This is the link to see what I have done, all the reports and everything. You can see for yourself. I can open the hyperlink later. So what I found is that when I was looking through the Health Cubed contacts, I heard about Indian School of Business, and I met a gentleman called Manish uh, Ranjan, who is from Bihar, but he moved to Hyderabad. He, in about 8 years ago, he won a competition through Clinton Foundation to do non-communicable diseases through digital platform, and in the urban slums. So he got $1 million, and then he put about another 1.5 million. Now he has a whole platform. So I loved it when I saw the demo. And now Global Teleclinics, we have white labeled this platform, and we're going to do the second phase. I call this program Deepam because digital integrated prevention and management. Uh, if we can focus on prevention and try to manage these people with simple things, probably it might resonate with them, rather than trying to deliver full level healthcare and complex disease management in rural health. To simplify it, uh, when I did lifestyle medicine boards, it was all about what my grandmother taught me when I was a kid. And we have moved away. And here's the evidence from the labs that we have done random sampling for all these villages, and the disease burden of non-communicable disease so high. So I thought, if we can have disease management and disease prevention platform. And my goal was to kind of proactive, coordinated, continuous care, care, and patient screened, reduce hospitalization, lower health costs. That's the vision of Deepam. And we we kind of talk to them, and they kind of already have done this, wherein they have community level population screenings. There's the primary, secondary, and tertiary, and it's a digital platform that can be used across. They also have artificial intelligence. They do risk stratification as low, moderate, and high, and basically they also have some recommendation engine, disease management, and critical care, and their goal is to improve outcome. So they have a patient user, a user app, they call the Sati app, or the if there's ANM in Asha. And I told them my experience has not been great, so we're going to hire a healthcare worker, and we're going to train them how to use the app and how to communicate with the doctor. And whoever is sponsoring these programs, they can just look at what's happening on a daily basis, uh, and we can change what happens. There's a doctor, program manager, and operation manager who they have their own view, and it's completely transparent. And one of the critical things is to have complete transparency in your technology platform when people are actually doing telemedicine. And we uh, they have already done working with uh, in that program at the urban slums. And A&M Asha connects with the PHC Health and Wellness Center, CHC, and District Hospital. This is, I'm sure most of you are familiar with this. And they have created that, the entire integrated health. And they screen the diagnostic test, the diagnosis. And I now can confidently say that the American College of Lifestyle Medicine said position statement that you can completely reverse type 2 diabetes. So that will be my journey on trying to work on blood pressure. Completely you can reverse if people are willing to change and listen. Obesity you can reverse. uh, Obviously, uh, if you fix the 6 pillars of lifestyle, which is exercise, nutrition, stress management, sleep, addiction, social relationships, and then you fix the hormones, that's when you get wellness. So what I plan to do in phase 2 is the doctor will actually visit and examine all the patients, and he will put all the data in the electronic medical record. And then every day we give them medications for the illness. And then every day we'll monitor them through an app-based solution. If the patient can manage it, if they cannot manage it, the healthcare worker will be actually working as a liaison between the patient and the global teleclinics. And they can actually, this platform, you can do WhatsApp or telephone. And we wanted to do daily interaction, and I'll do a daily clinic. I call that the digital clinic, Deepam Clinic. uh, so once a month the doctor goes there, and every evening they can actually call 6 to 9 after they finish their farm work, before they go to bed. So this is how we created workflow. uh, and so uh, So the point is, we are actually giving them the medications, the low cost, and the budget is about $1,000 per month for this medications, the doctor cost. So we are paying 10,000 rupees for the day to entirely screen all the, I mean, do the exam and all that, and in between for the telephone calls, another maybe 5 to 10,000. So this way, what I'm doing is I'm bypassing the registered medical practitioners. The RMPs, they are not trained, but they're acting as doctors, and the government, I guess, now is legitimizing them. But I hope that they have some kind of penalty also if they do mistakes. Uh, so, but here there is so many explosion of medical colleges. So you can get a village city guy to once a month go to the village, examine all of them, and each time he goes there, he kind of gets familiar with the patients. And you're actually taking healthcare to their doorstep. And uh, then in between it will be a digital clinic, and they have the healthcare worker will be the liaison, who will be very good at examining, supposing we want to do an abdomen exam, so he could be actually doing it and we can watch it. So now the American Telemedicine Association is actually giving certificate courses to train people to be the person who is actually enabling the telemedicine. And everybody will have a chart. Anybody from anywhere in the world can give consults on a voluntary basis after the pilot. We're creating a database of physicians who can give their hours, and people can choose. They'll So what I want to do is I want to create an Uber model of healthcare, wherein whoever has time, they will just be there on the platform, and anybody has any healthcare issue, they'll just say, I need help. Whoever is closest, you know, like, and then they'll pick up that case, finish it, and then document it. The more electronic medical record models you have, it will be a failed system like America. There, we have too many electronic medical record systems, and nothing talks to the other one. But in the Veterans Administration, there is only one, and it doesn't matter where the patient goes, all of them everywhere have to enter into one system. So then you'll have uniform charting, uniform history, duplication. There's a lot of benefits by that. So we actually did that. As I said, in the first 6 months, we're going to kind of manage the disease by giving them pills, get their trust, and then giving them lifestyle medicine education, and do the disease reversal. And labs will be uploaded, history and physical, and as I said, acute and monthly visits, and we can communicate, and healthcare worker will be. So the outcomes is how many positive patients through the screening in phase one, number of medications we gave to these people, because I want to make sure that I don't continue the medications. Hopefully we can change their lifestyle and educate them. And trust me, it's so simple. uh, if I have to say, because diabetes, if you want to reverse your diabetes, I don't know how many of you in this group who are listening to me have diabetes, do these three simple things. One is give up all the animal products, including milk, yogurt, eggs, dairy, all the animal products. Give up all the oil and eat as much plants and vegetables and fruits you want. You can see in within 3 months your hemoglobin A1C will change and will drop significantly. So I want to make sure that I manage these six conditions. What's the compliance with the medication? And it'll be a 3 month pilot, and how the labs have changed, and the biometrics, and how many health education sessions. So it's not like we educate them. We're going to give them every day like a smart uh, a tidbit, that it's like what I just told you, three things to reverse diabetes, which are easy and manageable, and how many phone calls, and how many patients we managed, and uh, also the disease reversed, the outcomes. So I'll be able to give you the input, but this is a new program, digital integrated prevention and management. I talked to a Dr. Bharat, who is in Gujarat, who works with the rural health hospital, uh, by owned by the Cadila chairman. And he said this is very innovative, wherein you're taking healthcare to their doorstep, and you're having real data to kind of intervene. And he said, we didn't hear about lifestyle interventions that you can reverse disease. So now you can actually do that. So, and telemedicine could be a scalable way that you can actually, and then Project Echo would be a perfect example of how you can enable education in a mass scale, and change the outcomes. So uh, any rural telehealth program, you first have to create a program, where to begin, and you develop your program. How do you implement it? How do you evaluate it? And one thing I found, I wrote a textbook chapter for telemedicine in India. I did pull a lot of articles. Maybe I didn't find the right ones, but I didn't see any programs per se that say, okay, these are the evidence-based programs that have been tried, and this is the outcomes. This is what we have changed. But all I see is these are the people doing it. So I guess we have to take that leap in trying to create, uh, toolkits. If a family doctor wants to do telemedicine, this is the roadmap. If an internal medicine doctor, this is the roadmap. If it's a heart doctor, hey, this is what you do for heart. Eye doctor, this is what you do. Give them the tools that they can do, like ophthalmoscope. And we do have some kits. When I was actively involved in the American Telemedicine Association, I saw some Indian companies, especially from Bombay, come and showcase their products. But still, I've really now, remote patient monitoring is such uh, primitive in India. There are individual devices coming, but we don't have comprehensive solutions. Uh, and I actually, we created an app, and we connected this again. I imported 10 units from Hong Kong that can do blood pressure monitoring remotely and we integrated all that through our app. But it took 2 months for the customs to clear those 10 devices. So all these things need to be changed in order to kind of change how we practice telehealth in rural areas. And obviously funding and sustainability and dissemination of best practices. And I think creating toolkits for each specialty to run telemedicine and how do they do it, making it easy for them will change the dynamics. So based on my experiences, the easiest and the cheapest is telehealth education, and you can do you don't even have to invest any money. You sign up with Project Echo, it's free, and you can do it. Um, Obviously, there are some things that you have to do with them, which is collecting data and giving it to them. So you can actually do that. It's a very cost-effective method. You can scale it up. They have the solution. You just have to be the person doing it. And uh, it's called Project Echo, extension of community health outcomes. Echo means, and I don't think using ANMs and ASHA workers in telemedicine will be really taking telemedicine anywhere. That's just me. I may be wrong, but that's my observation over the last several years. You should create I call that healthcare worker or Sati, and that person should be trained in technology and facilitate the visits. And I don't think desktop and all these networks will work. It should be very simple, app based and simple documentation. And it should be one thing that everybody uses across the country. Anytime you try to create multiple medical records, then there is no interchange of health information, and that's again a disaster. I think if we invest through telehealth education in patient education and lifestyle changes to prevent non-communicable diseases, we'll have more bang for the buck. I think you should do a hybrid model wherein in-person and virtual care, wherein that gives the patient bonding for the visit, and you examine them, you understand how their lungs sound, how their heart sounds, and then I think in phase 3 I'm planning to charge 50 rupees or whatever the RMP takes, because people have no problem going to a registered medical practitioner. I'll charge the same amount and have an MBBS guy once a month go there, do the exam in between, just between 6 to 8 or something, do a digital clinic and see how it works. And I think similarly in American model, we have telehealth resource centers. They're all manned by PhDs, and they actually go to any place in that. They have 5 regions in US, and each region, different states can actually reach out to them, and they go and help implementation of all the rural health programs. Uh, that's how I actually created a telemedicine cart. So, in order to create success and sustainability in rural health, these are the these are the factors and these are the key points to consider. Your vision should be clear, realistic vision of the purpose of the service, and the ownership should be deliberate and consultative services development with all stakeholders, supportive managements, and clinicians who champion the service by actively engaging and participating in service delivery. So I had the equipment put there, but if the clinicians are not engaged, because the DMHO said, "Sir, why are you bothering me? I have so many things to do." Even though the collector said, "Do it," but sometimes you have these issues. Adaptability, the trial and modify the service model. You can't just pick one model and then keep. You got to be adaptable and modify it. As what you have seen in these 9 years, I've changed the model of delivery in rural health probably 7 times, and I'm always remaining responsive to the stakeholders, and deliver cost savings or facilitate priorities in if services for health services, provide value, achieve comparable care with clinical benefits. So this is what we're going to do in phase 2. And so I don't have the efficiency is improved because I have a software now, a telehealth platform that really focuses on the diseases and managing the chronic diseases, because it's an epidemic in India. And I don't believe the quantity is marker, but how you take few people and do it and well. And as I said, Dr. Bharat, he said, if this all works, we really need to showcase this to higher authorities. And he has connections being from Gujarat, uh, and equipment also. Now I don't have much equipment, and it is a simple app-based solution that we do everything there and document. We have labs that come and do, and based on research, these are some of the dissemination methods for rural telehealth programs: posters or oral presentations at conferences, radio or television broadcasts, newspaper or print ads, direct mail marketing, webinars, social media, sponsored events, personal contact, word of mouth, online forums, and video or in person demonstrations. So, what do I do here in US? I have a concierge connected care, so people pay a yearly fee to be my patients, and I have an app. It's called Carium. It's a lifestyle medicine app that people can put in what they eat for breakfast, lunch, dinner, how much they walked. If they have blood pressure, I give them a blood pressure unit that is remote, they app based, and it'll just come into my clinic, and my nurse monitors every day. And pulse ox, I give them weight uh, for heart failure patients. COPD, I give them a pulse ox that's Bluetooth, and I monitor their chronic care management and remote patient monitoring. And luckily, government in 2 years ago, I've been doing this for the last 6 years, but the government just 2 years ago started paying for these services across the board. And there's a lot of patient education that I push through the apps. You can do it in the local, and I give them tidbits to kind of simple. So for the people, if you really want to change your own life now, right now, I want you to, I call them the six poisons. One is the processed foods. India is now becoming a hotbed. Everywhere you see packet foods or processed foods. It's a disaster. It causes inflammation. Then sugar, animal products, dairy, refined flours like maida, white rice, and gluten. If you can just stop these six and eat more plants and vegetables, dals and brown rice and millets, you will be amazed to see how much good happens to you, because it changes the inflammation, insulin resistance, and the hormones also. You need to check, which I don't think in India it's pretty advanced. But this creates a holistic approach to care. And the lessons learned is keep it simple, use a simple app based model to do telemedicine. Uh, don't create a lot of hoopla around trying to integrate so many things and do it, because we don't have the bandwidth to support all that. And use a model wherein education is what kind of is transmitted more for the visit than just the acute visit and the disease management, so that you get more bang for the buck trying to deliver telemedicine. And I'm not so sure the government is using a hub and spoke model. I don't think i- i- it's going to pan out across India, because we are so heterogeneous with our things in the states. uh, I think it should be a state owned program, and they should connect with the districts, and because we have a very good system and that state model. And unless the federal government creates a budget and creates an app and EMR that everybody can just use it, whoever wants, and there is a budget to support that, uh, will not work. But this is what I have kind of envisioned, and this is what I do in US. Uh, I'm into technology and medicine to change outcomes, and stay home I will is basically what it is uh, successful telehealth, aging yielding high outcomes, and minimizing events. I will involve, learn, and live, which means it's a person centered model of care. And I'm trying to do adapt a modified version in rural, trying to give them uh, care through digital clinic, and with a hybrid model. And I hope this was helpful for the audience. And thanks again, Dr. Ramesh and Ruchira, for really giving me this opportunity. It's one of the best days of my life that I could talk about all the work I've been doing in rural India.
Thank you, sir.
Thank you
Thank you.
so much, Dr. Gokula. Thank you for a very interesting presentation. I do hope that you will be sharing it with us for our further dissemination and sharing it with our participants. Dr. Shaktivel, it's over to you, sir.
Yeah, thanks a lot, sir. I think I mean I'm really happy that you are continuously inventing and the way to be effective. Especially, you have connected more on wellness aspect. I think yesterday we spoke more on treatment and diagnosis and treatment, and today I think your presentation was more on ensuring wellness through telemedicine. I think that aspect is really also important, and it could be like you said, it could be the first step or the easiest step to I mean really focus on. I think that's what we get from your presentation, that through a simple way we can ensure telemedicine takes off as a education wellness, looking at wellness, what the government is also trying to do through e-Sanjeevani and others. But probably I think your whole lecture was been around this aspect, so which was very important input to us, and definitely this is doable from I mean what I've been always talking to you or writing emails on what could be done I mean on a rural scale in simple way, what could be done. So that's what is a key, like to spread the concept. I think I mean like entrepreneurial model is also one thing that we were very keen. That's what again and again I was talking to you or talking to Dr. Agarwal when he was here. So I think I'm really happy, and we'll see how we can take it up to our ministry through we'll be writing a fact sheet or I mean, on a policy brief on this. Basically, that's what Ruchira and is tasked with. I think probably we'll come up with a policy brief for our ministry to engage with telehealth or telemedicine in rural India. So that's what the task is going to be after this workshop. So we really thank you, sir, and we'll bother you again. I think we'll be connected, and we'll see how best we can use take your experiences and knowledge when we progress on this. So
Yeah,
thanks.
and I think, I mean, because Project Echo, one of the requirements, I couldn't start Project Echo in India because I'm not a not-for-profit. Uh,
Okay.
but if somebody at your level, you reach out to them and say that I want to participate in Project Echo, you can participate, and
Okay.
you'll get the platform easily, and you can be. And I would love to work with you on this Project Echo, trying to implement lifestyle medicine in rural health, because you can see I have the data. These are all SRL Diagnostics is a national diagnostics lab,
Yes.
NABL certified. So the data is accurate. It's not like you're getting it from any other lab. And if the disease burden is so high in only 51 villages, and I've done in 5 states, so I'm sure it's coming out, plus minus 4 5 around all these 6 non-communicable diseases. And if we can do that with low cost, because you're not paying, the government will not pay anything to Project Echo. It's free platform that you can use. And then we create clinical models around that for education and try to do that. I would love to do that. I'm very involved with the Indian Society of Lifestyle Medicine because I've become very passionate. I'll be very honest with you. Only 3 years ago, I learned about lifestyle medicine, and I changed myself. And I've said, I'm going to dedicate my life to be doing disease reversal, not disease management. Anybody can do disease management, but disease reversal, it's very easy. Simple things. I just told you the 6 poisons I call, and you eat a lot of plants and vegetables. You just try it for 2 weeks. You'll see so many good things happening to you. And if we can inculcate this simple, sorry, I mean, and now I actually do labs for inflammation, insulin resistance, and it's too early. I have few people who 6 months later they did and they reversed it, and so it's like more talking. There is nothing gadgets, like echo stethoscope or Bluetooth remote patient. This is just a simple tool that you can do and intervene into the disease process and reverse. and then change their outcomes.
Yes, sir. So I think thanks a lot, sir. Ruchira, I would request you to do the next, like you can ask participants if they have
Yes,
questions.
yes. I mean, we would like the participants to interact with Sir because it's a rare opportunity for you to, interact in this kind of a platform. So my request to participant is that please use the opportunity, unmute yourself, and talk to Dr. Gokula here. And it's late night in the US, so we will not be able to catch him for the whole session probably. So I request you to be quick and ask your questions. Or alternatively, you can also drop your questions in the chat window, and we would be happy to read it out for you.
So, Ruchira, they say that if people don't have any questions, either I was
Yeah.
not effective, or, or
You will
they heard
wait
it
for
all.
Right. I think it's a bit early for them. They need a cup of coffee probably. Yeah. Yes. Um,
So, I hope I didn't go fast.
uh, no, no, of course not, sir. Your presentation was fine. People take some time to kind of for this to sink in and the questions to start coming out, but in any case, sir, as I was telling you that this topic, the bringing telemedicine to rural areas, our director general is extremely interested, and it is actually him who suggested the topic to us to take it up for a workshop. And we are trying to find out where the Ministry of Rural Development and the programs that through MORD we are doing, where these programs can kind of intersect with the health division and bring telemedicine to areas. So uh, one of the main ways through which we reach the community are the women self-help groups. So National Rural Livelihood Mission kind of takes up these 8 crores of women they have brought into the self-help group system.
Wow.
So whether we can leverage that, because I was very hopeful when you said that basic medicine, you don't need very advanced medicine,
No,
training. Some basic things you can train. Some of it is also about awareness. Some of it is about lifestyle. So those kinds of, if we can kind of build small modules around those messages and those knowledges to
absolutely.
these women, and kind of have like a mass level training for them, and onboard them in this health initiative. Also, if there are some small tools that need to be given to them, somehow we can tie up with CSR and kind of provide it at the village areas. In terms of I don't know, in terms of technology transfer as well, MORD has several initiatives uh, through which we can think about how to transfer technology. So these are some of the things that we are thinking. And see, there is already a hand raised. uh, Dr. Jabaretina, please unmute yourself and you can ask your question.
So, good morning, sir. Even though it's late night, thank you so much for helping us to understand so many things. I have 2 questions, sir. The first
Sure.
question is actually senior doctors normally they are engaged in telemedicine, and because I discussed with one of the doctors, they said senior doctors, if they engaged in telemedicine, they could able to take decision very fast. This is opinion. What is your opinion, sir? The people who are involved in telemedicine should be senior, or anybody based on the interest and technical knowledge they can do justice? I don't have idea, sir. If you, because you have been engaged in this so many years, so if you could tell us, that will be very helpful, sir.
Yeah, thank you for that wonderful question. When electronic medical record was, I've been living in the United States 22 years. My first exposure was at the University of Michigan for electronic medical record. That's 2004. And guess what? After that, I came out. There was not much of, but then the government made it mandatory. You know how many older physicians retired in US? There was almost 30 to 40% of people retired because they didn't want to manage technology. So, so I'm sorry. I disagree that older physicians or experienced physicians. I would rather give technology to the younger physician, because in the last 10 years, there has been significant change in the amount of devices that people are using. And for the first time in the history of mankind, a device actually took over the number of people on the earth, and that's the smartphone. So, any technology that you do, if you can do it through that piece, that's what works. And who does that better than younger physicians? There are a lot of older physicians who can't even create a PowerPoint presentation properly. So what I normally tap into retired physicians because they have time, they have the knowledge, but again, I struggled with them trying to teach them how to uh, open this app, that app, and then try to kind of coordinate. So my experience has been the younger physicians are better, and that's why I'm using young MBBS people, because I don't think the rural people should be getting care only from RMPs. I think the MBBS people should be the ones giving care. And why not? When they're getting trained for 5 years, 5.5 years, and I understand everybody wants to be in urban areas and all that, but this hybrid model takes that away. Once a month going is not a big problem, and if you pay a chunk of money for that day, there is financial incentive, so people will go and come back, and you get the rest can be all digital. So to answer your question, I think young person should be the one doing telemedicine.
I hope your question was answered, Dr. Jabratina. We have
And Dr.
well,
Jabratina, I should also add that specialist care uh, is the people, it is each different. So specialists have a role, but majority of people actually need primary care in India. Rural health doesn't need specialists. Rural health needs primary care.
I have another question. Actually, yeah, now in case if you have to revise our curriculum, sir, what is your suggestion, sir, for this younger generation, because they have to take digital healthcare in their academic curriculum? So, what is your suggestion, sir? What are all the things they have to learn when they were in the MBBS course? Can you please tell us, sir?
Oh, that's a big. It's so I guess what you should do is you should create a module with all the digital resources that are there, like M Health, apps. So I actually created my own app that I provide education, and patients can download it free. So you should have the technology that enables telehealth, the apps that help, and what is actually proven to be helpful, and kind of teach them and give them the tools to use and actually demonstrate telemedicine and do it while they are in medical school, which is more important than, because if you go to the American Telemedicine Association, it's like so many devices, so many platforms, so many. I mean, you get confused after a while which one to use, what to use. Uh, Rather than and getting lost, and I got lost, I'll be very honest with you. I got excited in the beginning, this that, and I created a telemedicine cart and did a lot of things, but there's nothing better than just keeping it simple. Use one platform with low bandwidth, and bring in remote patient monitoring if you can, and check the vitals. And now I see a lot of innovation happening around that in India, uh, and you kind of get this going. Sorry, Santosh Podar raised his hand.
Sir, good morning. My voice is clear, I think. Pranam,
Yeah,
yes.
sir. Yeah, I am from Bihar and I have been in electrical engineering, but is passionate for the telemedicine sector. Want to work for the rural people around me. Uh, what do you suggest for an engineer? How could they go in deeper into know all this and do something?
I mean, if you're really good at creating a device, Health Cubed, what it did is it brought several parts together and created diagnostic services. But now, if you can put uh, an indigenously made in India stuff that can check vitals, several things, you know, uh, we used Hong Kong things and we created an app and we are trying to do that. No, if you can create a unit that you can check blood pressure, check pulse ox, and they're already coming on, okay, and check their heart rate and the heart rhythm. Now there are devices that check heart rhythm only in India. But if you can do that for rural health, because what do you want to prevent? Heart attack, because people die. No, that you, if they have a capability of checking if their oxygen, if they have blood clot in their lungs, people die. Uh, so you look at if they have any pneumothorax. So, but so what do you basically need for all this? You need checking the pulse oxygen, you need the heart rate, you need blood pressure, you need the temperature, and then if they can check weight, which will be helpful. And if you could do an integrated device, low cost, uh, because that if the patients can actually use it, then remote patient monitoring becomes an enabler. Because here I actually give the device to the patients and I bill the insurance, and still patients are not excited about it. So in order to do that, in the beginning probably a healthcare worker should carry this device and help. you know i I gave a proposal to Mr. Naidu. He was so excited with that, and he gave it to the principal secretary through my junior in med school. We call that Sadika Mitrulu, wherein these people know the villagers very well and they interact with them, and they actually enable this whole thing, and they actually teach what the government programs are all. How many people in India actually know what are the facilities that government is actually giving to them? So you can have that kind of uh, device that will bring all this into one simple device, small and easy, low cost. And as an engineer you should be thinking that. I don't think you should spend time in trying to do lab test. I think you should try to do this basic vitals at a very low cost.
Yes, sir. One problem comes. You were mentioning the Uber model, as far as I could understand. So I'm not going to do the instrumentation portion. Uh, Basically, I want to get involved into it and see in the pros and cons, and then, if possible, I could modify or do something in that.
Yeah, well, what I meant by Uber is, let's think if we have a platform that people can actually, I mean, Uber is all over the world, right? I mean, if it's in America, every state, wherever I go, I ask for a car. There are 5 drivers. One of them says, you pick one of them. Same thing with healthcare on the digital platform. Because if you depend on RMPs to deliver care, it's not going to change the outcomes. If you give people like who are retired doctors, who are professionals who or MBBS people who are preparing for PG, you enable them and say, okay, for a small money, you can do telemedicine visits. Then they're all waiting. Everybody signs up, their license are verified, and you take away all the rules across the states. You have one unified platform. Whoever wants any medical issue, they can just. I understand that there is a language problem, but Telugu people will pick up the Telugu. You can create all those on the platform. If you're a Hindi speaking, so that's what I mean by Uber model of telemedicine. That uh,
Yes, sir.
so somebody is asking.
Yeah, there are two questions in the inbox as well, sir. Let me just read it out. One is from Dr. Raghunath Saini. He's asking, can echo model be utilized for preventive health or good health without medicine? And
Absolutely. If you have a not for profit, you have an idea, you present it. It's very simple. There is nothing big paperwork. It's not EKO, it's ECHO, echo, extension of community health outcomes.
right. Sir, the second question is from Rushikesh. He's asking a very good, I mean, his first is very good presentation, sir. Acha, this is just a thank you note, I believe. There is no question here. Uh, then Akanksha is asking, don't you think that working out telemedicine in rural India is difficult for older people? because of illiteracy. They are not very good with technology. Children live in cities and need someone to access it. So any
Absolutely. It's a very good observation, and I saw the same thing. So that's why we are training the healthcare worker, and we call them Sati. Uh, and then the Sati has a Sati app, and he actually helps facilitate all this. But the patient also can, through WhatsApp, because everybody is now using WhatsApp, and they can use through that. You know.
So are there any more questions? Any hand raised? I don't see any.
Telerehabilitation. Yeah, it's a very interesting topic. Somebody just posted. Uh, you can actually do telerehabilitation. I don't know if you get paid in India. In America, there is, and but again, you have to have the other person. What they have noticed in telerehab is the patient should be actively engaged, and they should understand very well. I don't think even in urban areas, our Indian population have a lot of high literacy with health. You know, I just today my last patient was an Indian lady from Bombay, and I was giving an injection, and it was quite how much to cajole and try to help understand. So it's a challenge
Yes.
with
There
the
is a strange
telerehab.
aversion to institutional medical care here. And people will do
Yeah,
all sorts of things, but then not go to doctor and take professional help. That's I don't know. That's
yeah. So
probably doctors.
yeah, but telerehab is a great way if the patient is engaged very well, if the family is engaged very well. You don't need to go home and do the rehab evaluation, or they can just come once and then every day you do the session. That's what happens in America. They come once, they get the plan of care, and then every day the sessions happen through telemedicine in rural areas,
Right.
because you got to assess the patient, right? The first visit.
So I don't see any more questions here. Um, it's a
Santosh
Santosh.
Podar.
No question. Yes.
So one question is still there in Bihar, because I have been living here for years. The information and the technology is not very much. People are not friendly with this, and because of this, there comes the problem. But if the government can be mobilized, and awareness can be given to the people, so that on a middle of survey we could do something, and then involve them in telemedicines later on.
So one thing I can give you, that's my thought. Indians,
Yeah,
we are we are we are always running after a few things in life, right? One is pictures, one is cricket, right?
yeah, yeah,
So we kind of die for these things. And so when you're trying to engage these rural people, if you kind of engage through videos, when you're doing education videos, that is helpful for them, because everybody is having a smartphone. I've seen a lot of smartphones in rural areas too these days that people are buying. Correct me if I'm wrong. In Bihar it may be different, but I'm
yes,
talking
yes.
about Andhra and Telangana.
No, 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 no. Smartphones are here very much, but the thing is, they have not seen medicines integrated with the mobile, so they have certain difficulties in going through this. They simply, if they have any problem, they'll go to the physical doctor if there is any. Uh, there is a need of mobilization and making awareness, as far as I understand.
Absolutely. And COVID, I think, changed the dynamic. I had a lot of resistance, and people said, you won't succeed. What's the point? And all. But I just knew in my heart when I started, the technology is the way that you can scale healthcare, and you can change the dynamics of healthcare. And here I am, that we are able to do it after COVID, that things changed. But to make your point clear, the education has to be at multiple levels. I gave you in that. I'll email that to Ruchira, where based on research and evidence. Sometimes it's media, sometimes it's posters, sometimes it's like videos. I've seen videos work well. Once they get engaged, in watching that. And I hit the points, like if I'm talking about something that is local to them, that's when I have seen that things work better, rather than if I'm talking about heart attacks to a Bihar rural area. If I talk about uh, dysentery and cholera, I'm just giving a example. Then they're more interested because they had somebody who had cholera the other day, and then they'll and you start engaging them through that way, giving them information.
And what about if UN can be given some, if it can be allowed, if UN is interested in doing all this?
Yeah, I mean, UN is a big body. I think CSR funding should be the way that you should approach this.
Yes,
In
UN
my,
also works with their set, goals. It's not, you cannot take your proposal to UN. UN will come with their proposal to you. So
right,
the other way around is rarely the case. Right? You take any thing, UNICEF or any other bodies which work in rural areas. It's their work. They will take it to you. If it aligns with your work, you can work with them. But
right,
then you taking the proposal to them and them funding you, that is usually not the case with UN.
right. Why you can't even get into UN? You need
Yes.
a lot of permission
It's more,
to get it.
practical if you go to a CSR
Yeah, you
funding.
go to a CSR and explain to them. A lot of people will have a lot of alignment with rural health, and you should know which CSR is, aligned with rural health, and then apply. And I'm sure you'll get it. And
Absolutely.
there
And
are
we will
grants.
be happy to help you in finding such proposals. If there are any, we'll be happy to share with the group, etc. And
Ruchika ma'am, because I was not present in the yesterday's training session, so there can be some levels of
we will
misinformation.
share the video. It's everything is recorded. We'll share the video. You can catch up. No issues.
Okay, okay.
Okay.
And sir, we need your help in doing all these things in here also.
Sure, I'll be connected with Dr. Ruchira, and I would love to contribute whatever I can. I believe strongly about rural health in India. That's one of my dream, and I think I'm pretty close to that. If I get the Deepam project right, I think I got a model that is simple, effective, and you can scale it.
And I thought UN because if awareness can be made through UN,
No, no,
it becomes
United Nations, you can go to UN like that. It's better to be local.
Right. If there are no other questions, let us close the session today. We have kept awake for quite some
No,
time.
no,
It's
no, I'm happy.
midnight.
Thank you.
Yeah.
I hope it was all helpful,
Yeah,
Ruchira.
definitely. There is a lot of excitement and hope here. Maybe we'll be able to do something good starting from here and take this forward. And as I was saying, our ministry is interested. Like 2 years ago, before COVID, talking about telemedicine in a government, setup, it was
Oh,
unimaginable.
yeah, there
As you
was
can
so much
see, this
lethargy.
is what an epidemiological failure brings you to, right? You understand how vulnerable you are, and now you want every possible, solution on the table, and you want to. Everybody is open-minded now because we have
Right.
got a
In
shock.
fact, we did quite a lot of exercises on Zoom platform. We engaged a lot of rural workers across the country. So NIRD took a lead in
Yes, sir.
terms of
And actually,
spreading.
I don't know, I was talking to you the other day, sir, because once a technology enters, it's only a matter of time that it will be adopted. Because I don't think that there is any going back here. Because initially, when we started these online programs and Zoom based and Google Meet based programs, there was a lot of chaos, lot of confusion. I mean, each program needed a separate training for the participants to train them how to use the program. So we will have a main training, and before that we will have a short training to train them to how to use that training. So now over 2 years that whole thing has gone. People know how to use Zoom, people know how to use Google Meet. So I'm sure that the similar kind of advancement can be there in health as well. So as time passes, we'll be able to make people more comfortable with new initiatives.
Yes.
Absolutely.
So, Ruchira, I think you can conclude.
Let me quickly check the chat inbox. Yeah, there are no other questions. So let us thank Professor Murthy Gokula for taking his time out, and on behalf of all the participants who are here. Some of them are, in fact, medical officers and health officers in different states. Some of them are working with the communities. So on behalf of all the participants and National Institute of Rural Development and Panchayati Raj, we really thank you for your time and the presentation, and we hope to work with you in the future as well. Thank you, sir.
Look
Thank
forward
you,
to
sir.
it. Thank you very much, Dr.
Thank you.
Ramesh and Ruchira. Good
Thank
night.
you, sir. Thank you.
Thank you.
We'll be in touch.
We'll be in touch. Bye.
Thank you, sir.
Ruchira ma'am. If you could help me to adding in the WhatsApp and then getting the information, all the things,
Yeah,
because I'm
definitely.
not from this background. Totally, I'm of different background. So if little by little my interest will come, and then I will
Yeah, we will
try
share
to.
all the resources, Santosh. We just hang on there. We'll share the resources and you can get updated.
Make me interested at least
Yeah,
in doing all this. Uh, through your guidance, we could do better.
right. Let us move on. So, Dr. Gokula's presentation was the last of our technical sessions. And as we had told you yesterday, that we would like to hear from you and take your inputs on this possibility of taking telemedicine to the villages. And, kind of also note it down what you have to say and kind of include it in our proceeding as well. So, we don't have much time left. I wanted to finish early today. We have like probably half an hour for our discussion. So I would really invite our participants one by one to unmute and let us know of their inputs. Yeah, and let us know of their inputs in what they think about the possibilities of telemedicine and how the participants think that we can take it forward and coordinate through our ministry in that. The floor is now open. Please unmute yourself and let us know of your inputs.
Dr. Ruchira, can I have 5 minutes? After
Yes,
which I.
yes, Dr. Ganapati. Thank you so much for joining today and thank you
Okay,
so much
yeah,
for your
I'll have
time.
to leave now, but I just thought this is a very good audience. Now, I don't like to be personal, but unfortunately, one has to be personal to drive across the message. I'm just making a public offer to all the people here, particularly to the Ministry of Rural Development. I am talking on behalf of the Apollo Group of Hospitals. As you know, we have been engaged in this exactly for 23 years now. When I started in 1998, everybody laughed and ridiculed, but over the last 3 years, the world has completely changed. I don't want to give a big lecture, just 4, 5 specific proposals. I'll send an official letter to your Director General with a copy marked to all of you. And I'm very impressed and I'm very happy that you have taken these proactive steps. This is what we were desperately looking for 10 years ago, 15 years ago, 20 years ago. But nothing can stop an idea whose time has come. And I think the time has come now. So, number one, I understand you have a postgraduate diploma course in rural management. We would be very happy. I can take the primary responsibility. I have some excellent staff helping me in program management development. See, as I told you, we do almost 20,000 e-transactions every working day. Now, this requires a huge amount of people. We have almost 375 full-time employees in the telemedicine division and 1,000 employees who are engaged in various contracts. I would be happy to do a 1 day or 2 day, depending entirely on what you want. It could be as little as 6 hours. It could be as much as 12 hours. I'll ask different people to talk. I'll ask our financial officer to talk. I'll talk about business development manager, etc., etc. So that is one, offering you a 10 to 12 hour module. And I would be grateful if you could consider including telehealth. First of all, I think we should remove the word telemedicine. When I started the Telemedicine Society of India 19 years ago, I did not have the background, the knowledge, the wisdom which I now have. So the word telemedicine is actually not correct. The more appropriate word would be telehealth, because as even the previous speaker mentioned, the entire emphasis in the future particularly is not going to be on diagnosis and treatment, but rather on prevention. So we are talking of health, not medicine. That is number one. So coming back to this, we would be happy to have a 1 day, 2 days specific program exclusively for all your postgraduate diploma students, number one. Number two, I have enough material. Unfortunately, I'm not able to get the people concerned, people with an interest, a passion. The only way we can do this is somebody to register for a PhD. I don't know the full details of your institute or the full background, but I'm sure you have affiliation to some university, etc. We would be very happy to provide you A, with the raw data, B, with the technical help, B, with the infrastructure support, etc., etc. I got my PhD 30 years ago, and I'm an examiner and a guide for the PhD, including in telemedicine. So all these administrative things can be worked out. We will be very happy to give you, or to have even 1 or 2 candidates work in different parts of India, etc. The third thing is, anybody who's serious about it. We are only looking at people who are very serious. I can give them an internship. Of course, there will be some nominal. We are a non-profit foundation, so we just get enough money to meet our ends. But still, we would be possible to give a fellowship for a couple of months. Anybody who's serious about it, hands-on, you can, so they can visit various villages across India. They can study for themselves, etc. And under our guidance, I guarantee you, if somebody is very serious about it, I guarantee you at least 1 or 2 papers in an international journal. For youngsters, this will be a tremendous asset in their own future and development. And so we would be very happy to offer all this. And if you or one of your colleagues or whoever it is, you are most welcome to contact me later and have a detailed discussion on how to get. The most important thing is Apollo Telemedicine Foundation is more than happy to purely as a not-for-profit venture. We will be very happy to have a formal MOU, formal arrangement with your institution, and use our 22 years of experience, our not only the corporate hospital experience, but enormous experience in the real villages of the country. We want to expand. We want to, and we'll be very happy to share not only the good things you have done, but all the wrong things which we have done. So you learn from our mistakes. I think that is more important. Do not reinvent the wheel. There are enough of apps, there are enough of platforms, there are enough of things. What is not available today is people. Human resources are extremely difficult. And as I mentioned again and again, unless it is revenue generating, it is self-sustaining, it will die a natural death. So the most important thing is to generate. People have to pay for the service. Gone are the days when you expect everything to be free, but insurance is possible. State government sponsored, the huge numbers we have. So even if we have our own small insurance in small villages, 2 rupees per day. So if you pay 2 rupees per day, which even people below BPL today can afford to it, if we have 20,000 people, that will be enough to get it going. There are dozens and dozens and dozens of schemes, but we require people to help us, to support us. So this is a public statement I'm making. I'll be more than happy. Anybody can contact us, and we would be happy to help them on how to do it. But they have to be very serious about it, and that is the most important criteria. If there are any specific questions, I'll be happy to answer them.
Thank you so much, Dr. Ganapathy. That's really excellent to hear. And we will definitely have a discussion at our organization level with our management, and get back to you with some concrete proposal to kind of work this out and take it forward. I see a hand raised from Neeraj. I don't know whether he has a question to me or to you. Neeraj Das, can you please?
Yeah, I just like to share. I don't have a question. I just like to share my opinion. Previously, you said that if any of the participants had suggestions,
Okay. So, is there anything that somebody wants to ask Dr. Ganapathy? He also had a session with us yesterday, and we did not have much time to interact yesterday. But if anyone has anything to contribute at this level, or we can move on with the discussion.
So
Very good morning.
Ruchira, I would like to say something to, I think, what Dr. Ganapathy has offered. I think I'm really happy, sir. I look after the corporate social responsibility initiative along with Ruchira here in NIRD, sir. And Ganapathy, sir, am I audible?
Yeah, very much. Very audible. Please go ahead.
I think your offer is excellent, sir. Like student will benefit, like because rural management students, we don't give a solid health aspect in the course. I think probably this can be a boon for them, like a session or 10 hours of session would be really helpful. We'll put it to the postgraduate diploma section.
Yes, and I think we should talk about the MOU at the
the MOU definitely is. I think already we work with your. I think under the DDUGK skilling program, we have some MOU, and we work with the Apollo. And I think I don't know which division looks after that. The skilling, I think they are working with the Apollo group. That's what I understand. Definitely looking at telemedicine, and I think there is a lot of potential. And one of the thing is like, I think what Dr. Murthy, when he was talking also, I was saying the self-help group, that's our biggest clientele, which
Yes.
is available with
We
us.
are,
And
yes, sir.
yeah,
And we are also talking about telehealth education at this
yes,
point.
Yeah,
So
yeah,
can
yeah.
that's
As I mentioned yesterday, see,
sir.
we have 2,000 consultants, and I'm hoping I can persuade at least 50 to 100 of them very familiar with different languages. I personally did this for 5 years with MS Swaminathan Research Foundation, but then there's only this much an individual can do. So if an organization like yours takes a primary responsibility, we will supply you with consultants who can talk with absolute authority in Hindi, Telugu, Marathi, Gujarati, whatever you want. But you need to, we will even take the responsibility of connectivity, contents. See, course content is very important, which I'm confident I can generate. But then the getting the beneficiaries, this is where you would come in. And today with technology, we can do multi-point video conferencing. I can give a talk on recognizing the dangerous headache with 100,000 villagers in 2,000 villages spread across with a single talk, and simultaneous language translation facilities. I mean, there are so many things we can do. So promoting health literacy, patient empowerment. There is enough scientific data, particularly from the NHS UK, which shows that 60% of strokes, myocardial infarction, diabetes, hypertension, etc., 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 could have been reduced or prevented if only we are not promoting health literacy. While government of India is doing everything to make people literate, health literacy is something different. And let me be honest, all of us want to do something, give back to society what we got from. But I am not Mahatma Gandhi. I am not prepared to go and live in the villages. On the other hand, every one of us are more than happy to spend 1 or 2 hours voluntarily as our contribution per week. We're sitting in the comfort of my house. I can talk to 1,000 people on different things. There'll be no charges. We'll do this pro bono. This is our contribution to society. But then we need somebody to arrange everything. So I make an offer here that we will get you consultants to talk in the local languages. So 100% scientifically valid data with PowerPoint presentations on that. We will require some small funding, which an organization like yours should not find it difficult to do it. It will be done by you with the Apollo Telemedicine Foundation assisting you. So you are the primary driver, you are the owner of the project.
Yes, sir. Thanks a lot, sir. I think we'll be in touch on that. I think
Okay.
that's
Thank you so
thank you
much.
so much.
thank you so much, sir. We'll definitely talk about it and take it forward. I had a hand raised earlier from Neeraj. Please unmute yourself and.
Yes, good morning, everyone. I'm Dr. Neeraj from the state of Assam. Yeah, I was working like from the last like 4 years in the rural sector as a medical officer. Then now I'm presently from the last 1.5 years, I'm exclusively engaged with tele consultation only from our state hub. So I will just like to share my whatever I have observed during this tele consultation. So I think, like Sir has said, we cannot stress the much about the importance of telecommunication and telemedicine. This is the future, I guess. So we are already doing it in our state. The mediators, like we call them community health officers in our state. So like Sir said, one point was discussed. If people are not going to get anything, they will not come. So no matter how much we improve our services, people have to come to avail this, right? So I think to bring people, they have to get something. So like say, suppose I see a teleconsultation case, I give a medication. Suppose the patient comes for referral after doing the test and everything. Suppose he needs further treatment at a tertiary care. If the community health officers are not able to provide them an ambulance or say something else, they won't be able to, they will lose the faith in this process. So I'm trying to say is that if we can involve more of the departments, not only health, then it will be helpful. Say like suppose about one of the dental doctors seeing the teleconsult cases, he or she observed that fluorosis cases are there, and it means the dental enamel is being damaged. So that area water may need testing. So if we could involve like public works department and other department, it will be I think very helpful to give the services to people, and people will also be happy that we went to only for a medical consultation, but our village is being our water is being tested, and definitely we can approach this line to get our things done. So I think they'll be very happy to if we can indulge other department through it. And health is very important because people, the maximum number of people exposure with a government department is through health only, I think. Because people only have some work, they will go to some other department. But for health, we are in maximum exposure with the common people. So I think this initiative, whatever we are doing, is very nice because health is very important in getting close to the people. We are the closest to the people, I guess. So this is my humble opinion. Means I mean to say that if we can involve much more department, it will be very helpful to overall uplift the conditions of the rural people. This is my opinion.
Thank you so much, Dr. Neeraj. That's actually very interesting because when we prepare the policy brief, a section of
Right.
it we will also dedicate to these interdepartmental and interministry
Right,
coordination. So at
Right.
that time, I would really like to send you the draft if you want to have a look at it and give your comments
Sure,
to
sure.
that.
Yeah. Okay.
Okay.
Sure. Thank you.
Sure.
Thank you.
Uh, is there anyone else who wants to give their input on how to take telemedicine forward or their experience of telemedicine in their area or what are the challenges they have seen?
Hello.
Yeah, Santosh.
Yeah, Ruchira ma'am, one question was coming. Basically, I am working as a political consultant in IPAC these days. And hello,
Yes, you're audible.
are you getting my voice?
Yes, yes, you're audible. Please.
Okay, okay. So, and further, so as far as the interest is concerned, I am interested in doing all this, working with all this. So, the requirement for if higher education is needed, I have already done B.Ed and what other things that I could do. Basically, this is workshop, and I want to get answers to all those questions so that I may do in a future way.
I did not. I was not very clear about the question that you asked. You want? What are you exactly asking?
I exactly asking if the institute is offering some PhD as Ganpati sir is saying.
NIRDPR has a rural management course, postgraduate diploma in rural management. In fact, I think the faculty of postgraduate courses is here with us. Let me just see. Dr. Sucharita, are you here? Can you hear us? Am I audible? I don't think. Just give me one moment, Santosh. Yeah, Santosh, the faculty in charge of the postgraduate center is here. She'll join in a couple of minutes and maybe you can ask your question then. She'll be better qualified to
Uh,
answer your query.
uh,
Yeah,
Dr.
Dr.
Ruchira,
Sucharita, please.
I'm here. So let me know what. Yeah.
So Santosh was asking
What is
what are
the
the what are the kind of postgraduate courses that you have what that he can take up. So
PhD
he's
courses
an engineer,
that
but
are
yeah? So
he
if
wants to work with the community in
yeah,
rural.
so Santosh is here with us.
yes ma'am, yes,
Yeah.
yes.
So basically,
I have
yeah.
done
So we
engineering
have.
and
Huh,
after that I have
huh, huh, huh.
done B.Ed, Bachelor in Education also. So I want to further into the
Okay.
telemedicine sector and want to exactly be a entrepreneur in this area. I have already been working as a political consultant in this place.
Okay, great. With regards to
If
the
there is any
courses that are
radar or
run, we have a Center for Postgraduate Studies and Distance. Can you hear me, Santosh?
yeah, I'm
Am I
audible.
audible?
Yes, ma'am,
Yeah,
yes.
so this is a Center for Postgraduate Studies and Distance Education. You can check our website. Okay. Now there are
So train and
two regular
calendars that are
courses that
given.
we run here. Sorry,
Yes. Yes.
Santosh, can you hear me?
Hello. Yes, ma'am.
Sucharita,
Yes,
you are
ma'am.
audible.
Hello.
Let me mute Santosh because I think there is background noise from his side.
I think so. Yeah, there is some disturbance there. So, can I speak now?
Yes, please.
Shall I speak now?
Yes, you're
Yes,
audible.
Yeah,
yes,
so
ma'am.
Santosh, it is like this. In NIRD, there is a Center for Postgraduate Studies and Distance Education. We run 2 regular courses and 4 courses through distance mode. So you can check on the website also. The brochure, the entire detailed course content and everything is there. So the 2 regular courses, that is for the batch wise we take like about 60 students per batch. So that is all AICT approved, and we also have 4 distance education courses, which is also AICT approved, which is like for 18 months course they are. So we have our regional centers at 4 places, 4 different places, and all examinations and all they do happen there. But due to COVID, now we having all examinations and contact classes at NIRD Hyderabad. So these 4 courses, one is on PG Diploma in Sustainable Rural Development, PG Diploma in Tribal Development Management. We have another course on PG Diploma in Geospatial Technology, and one more course on Panchayati Raj and Rural Governance. That is in association with University of Hyderabad. And the 2 regular programs that we have, it is on postgraduate diploma in rural development management, 1-year course as well as a 2 years course with more specialization subjects and all. So that is all. All right.
Okay, ma'am. Yes, ma'am.
If you have any more
In
questions, please
terms of
let me know on
telemedicine, there
this.
is no, in terms of
Yeah,
telemedicine,
Santosh,
there
just
is
one
no.
moment. Before we come back to you, there is another hand raised. Let us give chance to other people as well. Uh, yeah, I see Rushikesh, you have raised your hand. Can you please unmute and
Yes, ma'am. Actually, I'm a rehabilitation professional. I have questions to Dr. Ganapati. Dr. Ganapati has been giving several offers in through Apollo Telehealth Foundation. Does that apply in the area of tele-rehabilitation also? Because I'm a postgraduate.
Yes, I apologize. I think Dr. Ganapati is not here in the meeting anymore. He had to leave. But what I'll do is that I'll connect you with him. I'll share the contact now details of all our resource persons,
Thank
so
you.
that any of you have any individual question or any initiative that you want to bring to their notice. All of them are highly passionate people who want to work in the community. So if you want to take it forward, you can independently reach out.
Sure. Thank you very much. Actually, I'm a disability rehabilitation professional in the area of early identification of children with developmental delay. With the same passion, I've done my PG and in physiotherapy, and my thesis topic was tele-rehabilitation. I have identified 40 children with cerebral palsy, and have successfully implemented this tele-rehabilitation. It was found to be successful. So I wanted to start such services in rural parts of Telangana area.
Right.
Otherwise, I'm an employee of an autonomous body under Ministry of Social Justice and Empowerment, Government of India. So I wanted to start some services to children with disabilities, because what we see, we identify these children, but the follow-up doesn't happen because those people don't come back. The treatment procedure is very delayed. So this tele-rehabilitation would be very helpful for them. It has proven successful. So any help in this regard, I will be very happy. Thankful.
Dr. Ruchira,
Rishikesh, I think once we start the working on the policy brief, we will reach out to some of you and take your inputs as well, because I think it will be very interesting to have inputs from different states and people who has actual successful cases to present in the field. Dr. Saktivel, over to you, please.
yeah, Dr. Ruchira, I think now you can, I think there are doctors, you can go by name and ask their inputs if at all they want to supplement some of the things that they would like to do.
Yes, sir. I
And
mean,
we
actually, it's an open
don't
call.
want to
I
miss
don't
their,
want
yeah,
to
we don't
roll
want to
over.
miss miss any valuable suggestion because they must be also engaged in certain activities and they have not been speaking. I would request you to go by
Yes,
names
sir.
and maybe you can do. Dr. Lal is there, Dr.
Yes,
Goel
yes.
is
Dr.
there.
Amia Kumar is also there.
Yeah,
So
maybe you can take.
most of our participants are health officers and medical officers and
Yeah,
are
maybe
doctors.
their valuable inputs will be very valuable for us to uh,
Yeah.
take it forward. I think please do that. Yeah.
Right. So, as sir is saying that can we invite the doctors who are present here to kind of submit their inputs to the topic of the workshop, because we are really serious about the policy brief and we want to take experiences and insights from people who are actually in the practice. So, if we can invite you one by one and you can give us your inputs, and I uh, I don't want to go by any kind of, I don't know, pattern. I mean, I just want to give an open call. Just raise your hand and unmute and speak uh, whatever insights you have to this.
By
I hope
name
I'm
would be
audible to.
better, Ruchira. I think. I mean, you can just ask them their feedback and what they feel would be good enough. At least some pointers that we should
Right.
consider. By name, I think you may make them cajole them to speak. I think that's better. Yeah.
Okay, so can we start with Akanksha Sharma then? Because I'll just go one by one. Akanksha, can you please unmute and give us share your inputs on the topic of the workshop, please?
Hello. Actually, I'm not very educated about this, so I wanted to know about it. That's why I joined this session. Uh, but I really want to explore in this field. That's what I have to say.
Okay, thank you, Akanksha. No problem. I hope that it was helpful.
Yes, it was.
Can we move on to Dr. Amir Kumar? Can we move on to Dr. Amir Kumar, please?
Yes, ma'am. It's very interesting. I have been working at NHM teleconsultation service from Assam, and what I have realized over the time is that we have to design something differently, because uh, first thing is the faith or the belief, because actually what is sitting in front of our camera or in on video consultation, we have to believe him 100%, because he might not be the actual patient. And if somebody says that he is suffering from dyspnea, we have to assess it through proper video consultation. So may I request our dignitaries or some academicians to design something differently, so that we can assess properly through video consultation. Because if someone is saying that he is feeling some breathing problem, we have through video consultation, it may not be always possible to assess everything. What we have learned in our medical colleges is that we can touch and we can feel the patient, because we can touch them, we can assess them in front of us. But in teleconsultation, what is happening is everything through video consultation. So I really feel that we need something different to different courses actually to proper treatment, proper treatment. Thank you.
Right. It's noted. Very well noted, Amirji. We are moving on to Brinda Devi. Ma'am, kindly unmute yourself. Brinda Devi.
Yeah. Good morning. Myself, Dr. Brinda. I work in Apollo Telemedicine department, in Ganapati sir's team. So What thought I have to share is in telemedicine, like I have worked here for 2 years. What I feel is making the patients to come for a follow-up is very difficult, especially in a telemedicine platform. So counseling plays a very significant role, so that in even in some of the rural part of the country, still there is a thought that physical doctor will heal, but now there is a change in that. So proper counseling by the paramedics or whatever front line worker we are educating them. We also ensure that we are creating that trust in the first visit. So this is one of the input which I have to give. So the session was very useful. Thank you everyone for that.
Thank you so much, Dr. Vrinda. Let us move on. Next, can we have Sri Dharmendra Kumar? Dharmendra Kumar? I hope I'm audible. Sri Dharmendra Kumar?
Maybe you can skip. I think he's not responding.
Yeah. Next, can we have Dr. P. Lal? Dr. Lal, am I audible? Dr. V.K. Goel?
Good morning.
Good morning.
I am a state program of the HWC, and I'm looking after the telemedicine also from the state. The session was so informative and interactive. I just would like to add in that, yesterday also we told that in Himachal there is a very the constraints of the network connectivity is very there, and if we opt for the sport VSAT or ISRO, it cost a lot, up about 1 to 2 lakhs. It costs for one center, so it cannot be feasible for placing on the 2,000, or you can say in the hundreds of centers. So financially, it has some constraints also. So I would say that there should be some mechanism to be developed at the level of the government of India for pan India, that they can provide some provider and the reasonable rates and with the good connectivity, so that telemedicine services can be provided in better. And secondly, when we are giving the telemedicine services, it is just a consultation. But if the doctor prescribe any investigations or the you can say the medicine, the person has to go out to get the tests to be done, or to take the medicines. So there may be some mechanism that through the either from the Indian postal or through that the person can get the medicine also at their home. Those who are taking the telemedicine.
Right. Thank you, Dr. Goel. Next, can we have Dr. Vidya Chandramohan? Dr. Vidya Chandramohan? Can we have Dr. Jabarethina? Dr. Jabarethina? Doctor, yeah.
Ma'am, I'm really sorry. Due to external thing, I couldn't, for a few minutes, I couldn't able to contact. May I know what purpose, ma'am?
We are taking inputs and insights from our participants and existing doctors here. So we would like to really know what you feel, that how we can take telemedicine forward and what are the kind of challenges you think that can come. And if there are any other feedback to our program also, you can note it down at this point.
Ma'am, it's really very nice, ma'am. Thank you so much. The speakers you identified and you help us to understand so many things is really wonderful. Actually, we would like to know. I received one link, ma'am. In that link, they said about the training program. Actually, online, your nomination has been approved for detail of training program. Something I couldn't understand. What is that? What is going to happen? That part I don't understand. I would like to clarify.
We will explain. We will explain in some time. Let us conclude our discussion session, and then we will explain regarding the feedback, etc. Moving on to Dr. Raghunath Saini.
Yes, madam. This session is very nice, but I think there is a need to include some Harman medicines, which is really rural based, that should be included in the telemedicine.
Right. What do you mean by herbal medicine? Like, what is there any particular thing that you can? Some example?
Herbal medicine like this, the Arjun chal is very important for the heart cases.
I mean,
So
is it procurable, Dr. Saini? Like, can we buy it somewhere, or is it like you have to collect? And what
it
is
is
this?
available in the rural areas. Madam. There are some trees, Arjun trees are available in the rural areas. Madam. So we can use herbal trees, herbal medicine for the heart cases also.
Okay, we'll come back to you on that. I mean, I need to learn more, like how to kind of procure and.
Yeah. Madam. Okay.
Then, Dr. Rushikesh, can we have your input, please?
Thank you very much for giving the opportunity. Sorry for gate crashing with tele-rehabilitation always in your telemedicine program. I thank you very much for this today's program which you have conducted. It has opened a very lot of opportunities for me, who is completely ignorant with the already running field. Uh, Thank you very much. And I also had opportunity to listen to the stalwarts in the industry, and each one have given even they have shared the ways how we can go forward for a new person to start with this kind of services. Thank you very much. I look forward to attend similar programs in future.
Thank you so much, Rishikesh. Next, Jayant Khanna.
Yeah, hi. Good afternoon to everyone. Good morning to everyone. Yeah, ma'am. Actually, I'm a field of e-governance person. I'm working with the state government, Himachal Pradesh. I'm an IT specialist over here, and how I can like I was just analyzing the same, that how I can contribute to the same at the rural level, and what as a IT expert I can contribute in the field of telemedicines. As recently the some of the telemedicine centers uh, inaugurated in Himachal also. So the working and the how the equipment work and how the process goes through. So it was cleared very clearly. It was explained very clearly by the mentor, and hope it will be a work for the next few years in the Himachal also. But some of the point also taken by the Mr. Goel, that the connectivity and the internet is the crunch in the Himalayan state. So there should be some kind of monetary help by the government
Right.
for the all of the for the overall this all states of the India.
Right. No, there were some mentions about Starlink and similar, local network that can be provided. Let us explore a little more about this, because I don't think we have the technical capability to comment on that at the moment. But I'll just explore a little more before writing something on this.
Yes, ma'am.
Thank you, Jen. Thank you for pointing it
Yeah,
out.
sure.
Let's move on to Suvarna Raju next. Leila Suvarna Raju. I hope I'm audible. Leila Suvarna Raju. How about Minda Shalini? I think there is a network problem. Murali Krishna Voleti. I apologize if I am not pronouncing your names correct. I hope you understand. Murali Krishna Voleti. Naveen Kamble.
Thank you, Dr. Ruchira, and good morning, everyone. And I thank NIPDR for organizing this workshop. It was very today workshop. It was very insightful. I'm Dr. Naveen Kamble, working as a consultant at NHS New Delhi. I have one of the challenges that I have seen, and I just want to showcase them. Like before working in NHS, I was working in Madhya Pradesh for a development partner. So there we have this hub and spoke model. In Madhya Pradesh, there are many spokes, but very few hubs, very few specialists sitting at the hub. So what challenges we faced there was like there were many calls getting from the spoke, but there were because of the limited HR or limited specialists sitting at the hub, most of the calls were like busy. Were getting busy because many spoke used to call at the same time, and it is very difficult for the specialist sitting at the hub to answer those call at the same time. So we need to work for what should be done at this for this situation. This is the challenge that I want to showcase. We can discuss on this.
Okay, okay. Naveen, if I may ask you, do you have any written material or any publication on this model that you're talking about, hub and spoke?
No, Dr. Ruchir, I do not have the written model. It was the state NHM model, which
Right.
was introduced hub and spoke model. Yeah,
Okay, okay. We'll learn more about that.
yeah.
Thank you.
Thank you.
Next, can we have Neelam Sen? Neelam Sen? Neeraj Das? Neeraj Das?
Yeah, hello.
Yeah, hello. You're audible, Neeraj, please.
Yes, I already shared my point that regarding that if we could
Right, you started
entangle.
yeah, we started the discussion with your point. Is there anything
Right,
else you would like to add?
No, not much. Thank you.
Okay, thank you so much. Next, can we have Priya? Priya M. Priyanka Gupta. Priyanka Gupta. Rajiv Das. Can we have Rajiv Das?
Very good program, madam.
Thank you, Rajiv ji. Can we have your introduction a little bit, and if there is anything you want to add to the discussion?
Okay, ma'am. Myself Rajiv Das from Assam. I am
Yeah.
working with NGO, ma'am.
Okay.
The name of the NGO is Mission Notice. That's all, ma'am.
Okay. Thank you so much. Thank you.
Thank you, ma'am.
Yeah. We have Santosh next. Santosh, anything else you want to add to it? Santosh Poddar. There is one participant who has joined without the name. So I don't know who the person is. If you can unmute telemedicine consultant, I can see. Yeah. Please introduce yourself and.
Yeah, good morning, ma'am. This is Prashika from Maharashtra NHM. Me and my team has attended these sessions from yesterday, and ma'am, all participants and the trainers, statements who has taken the workshop, the subject was very nice, and it is very helpful to us to it means do a proper teleconsultations in Maharashtra. We are using e-Sanjeevani application from last 2 years, and before that we used prognosis application. In 2005 and 7, the ISRO has started the telemedicine. ISRO has supported us to start the telemedicine in Maharashtra. And now we worked on hub and spoke model as per guidelines of MOHFW. Thank you.
Thank you so much, Prashika ji. Thank you so much for joining, and I hope this was useful to you.
Yes, ma'am. Yes, ma'am.
Going forward, also, we will be able to coordinate and collaborate with you for more work.
Yes, ma'am. Thank you.
Next, we have Yadagiri K. Yadagiri ji, can you please unmute and can we have Yadagiri K? No. Have I missed anyone? Anyone who has not had the chance to talk yet, please unmute.
Ruchira ma'am.
Yeah, Santosh, please.
Okay. Because I wanted to know, see, I have seen gone through the distance education web.
I'm sorry. Can you repeat the question?
I have gone through the website of this institute and seen that distance learning courses are available. Dates are not near, so by the time
Santosh, I'll connect you to the relevant faculty and maybe you can continue the talk there because let us not use the platform for any other discussion at the moment. I'll connect you to the relevant person.
yes, surely, surely.
Okay, okay. So if there are no other inputs from you, let us also close the discussion session here. Dr. Saktivel, do you have anything to add to it and then we can close the session maybe?
I think nothing specific, Ruchira. I think you can wind up now.
Yeah, yeah.
We will communicate with them whatever materials you have, PPTs that you would like to share.
Right.
And then maybe in the future, whatever we are planning in this line, we can communicate to them. Yeah.
Right.
Yeah.
So, yeah. So, thank you very much. Thank you everyone for joining the session and staying with us today and engaging with our, our distinguished panelists and speakers. Before we wind up this program, my request is that, of course, based on your inputs, integrating what our panelists and our speakers have shared with us, we are going to bring out the policy brief and we are going to share it with our ministry. And I hope that when we bring out the roadmap to take telemedicine forward, we will be having a collaboration at the states and at the grassroots as well. So please do keep in touch. And if you change your contact numbers, if you change your email IDs, do let us know. You know our email IDs already. So please drop a mail saying that my contact number has changed so that we can also keep in touch with you in the future as well. And our WhatsApp group, of course, will be here active at least for the next 6 months. We keep the WhatsApp groups active, and we will be sharing any relevant materials or any plan that we have with you, so you can be on board on that as well. My other request to you is that from since yesterday, I have been requesting that please register yourself at the training management portal because this is a certificate program. We do provide certificate for completion of the program, and to do that we require certifying your attendance in the training management portal and accepting your attendance. So I am again going to share the link to join or link to register yourself at the TMP. If you have already done it, you can ignore it. We have already gotten your nomination, we'll accept it. But I will quickly do one thing. I will show you how to kind of register your feedback, because after we have accepted your attendance and we have certified your attendance, you are going to get a message which will give you a kind of an OTP and a password to log in. So I'll just share my window quickly to show you what to do with that OTP and login. So you are going to open this page, which is trainingonline.gov.in. This is, I'm also going to share this link in this chat window, and I'm also going to share the link in the WhatsApp group as well. And in this link, there is something called login as a trainee. So if you log in as a trainee, it will ask for a trainee ID and an OTP. Both of these things will be delivered to you via message in the number that you used for TMP registration. So once you receive that message, use the trainee ID, use the OTP to log in. After you log in, it's basically there are a few links and clicks. Find out the program that you are doing from the drop down window. Once you find out the program that you are doing, it is going to open a feedback form for you. It's pretty simple, 5-point questions, etc. Just give your feedback to the program and submit it and close it. So this is our request, that please don't forget to register your feedback, and definitely do register yourself in the training.gov.in in the TMP portal, because if our WhatsApp group is of course active, it will stay active for several months going forward. So if there are any doubts, anything else that you want to collect from us or connect with someone, feel free to use the WhatsApp group to let us know, and we're going to take that forward. So thank you very much. Thank you for joining us. Let us conclude the program today. We started a little early, so we are also ending a little early. Dr. Saktivel, I would really request you to formally close the program so that we can close it and move on. Dr. Satyvel, am I audible? I don't think I'm audible. Anyway, let us close the program, and I hope to have you in the future programs as well. And thank you very much for joining. Thank you.
Thank you. Thank you. Thank you.
Thank you all, ma'am.